Welcome everybody. I am Megan Villarreal. I am the Research Program Manager at the Cleveland Clinic. I did start as a coordinator way back when, and now I oversee the coordination team as part of the CRU. So part of my duties then too is in our 5 different aims of our CTSC grant, our team here that's going to be presenting is part of the special populations, our aim 1. So this is where our everything is coming from here and why we're doing this. So Jalise is getting the screen up, but I'm seeing a little bit of weirdness here.
Like gray boxes?
Yeah.
Gray boxes blocking.
How does it look now?
Better.
A little bit of a gray box still, but I think we can work with it.
Is that the top?
Yep.
Or,
yeah.
Okay.
Yeah, it's
so maybe
the top
it's
choice.
All right. Is it at the bottom now?
Yeah.
It is.
Okay. All right. So that was just the toolbar, but if there are any problems moving forward, just let me know.
I think we'll be okay with this.
Okay.
So I think we can go into the next slide, Jalise, then. Let's see what it looks like when we go on the next slide. Okay, perfect. So this is just the little introduction to what the CTSC is and what our piece of the grant is. Dr. Singer was supposed to introduce this part, and I do not see her on yet. So if either Charlotte or Noreen or Megan would like to speak about just what our grant is or any of that, turn it over to you if you want.
I personally vote for Charlotte because she's much more eloquent than I am at the end of the day.
I was voting for Charlotte too, Megan, if it's all fair.
Okay. So hub research capacity is one of 6 components in the large CTSA grant. And if you think about the term research capacity, it's how you get research done. But the focus in this grant, NIH turned the focus, instead of just in the past paying for visits to happen on a clinical research unit, this round, they want to pay for people who will get recruitment up. So the capacity to do more research and get studies done is important. And not only just recruiting from very convenient populations, they want us to recruit into special populations, which is very broadly defined. It can be age groups, it can be other disease categories, it can be more geriatrics, more pediatrics, it can be special populations of a certain type of category, nurses, whatever. It's very broad and allows us a lot of room, but they really want us to get lots of recruitment done, studies done, and with a very diverse group of people enrolled in them, because that makes results more generalizable. So that is our charge in this 5-year cycle.
Thank you, Charlotte. So if you guys then look in the slide, we don't have to read slides like we usually do here, but Jalise, if you go to the next slide. So kind of like what Charlotte said here, the group that we have and that's going to be presenting today, we are really the point people for doing the recruitment at each of our different institutions. And just a little bit of background on that each of our different institutions has a recruitment specialist, and those are the folks you're going to hear talk about the case studies. And we are part of a working group that works on how do we help research teams have a better recruitment plan? How do we, once they're already through it and they haven't recruited anybody, how do we look at their plans and see where the gaps are, what they need to do in order to get the studies done and get that recruitment? So whether that's electronically or maybe we need a better system of actually just approaching them. Maybe our investigator needs to be a little bit more vested in this study. So it just depends, like everything else, every study is different. So they really are the boots on the ground to try to figure out where the issues are and how we can remove some of those barriers to actually do the research. So what we're hoping with this group here is that, we're looking for providers, and you don't even necessarily have to be involved in research. We would like if you were, research folks too, but just the subject matter experts on your particular special population, like Charlotte described. And, what are the ways that we can get to those populations, in a culturally appropriate way, in a sensitive way, in a way that just is positive for both ends. So that's what we're here today to hopefully help discuss and have a really good discussion on. And we are hoping too that, as our recruitment specialists, that once we have these point people identified, that we can use you as a resource, and we can, you can help advise either the investigators that we work with or us ourselves, is just saying, hey, I have this team and they're really struggling with, getting diabetics, and they have 0 Hispanics that are involved in it. What can you do to help? And so we're kind of hoping that we can help make some of those connections today too. And then today, our whole point of today is hopefully to get some best practices established. And what works here, what unique to Cleveland is, are there things that we do best? Are there things that we could do better? Are there things we're still struggling with? Or are there different areas that we really have some blind spots to? So we're trying to look for that and too as well, and have a nice robust discussion about that. Next slide. So I do see that some people have joined. So before we get into our objectives, what we're asking everybody to do, the new folks that have joined, if you can open up the chat box. So we are going to be using the chat box, and we're going to be using the raise hand function. If you can just type in your name, your institution, and then what special population you're here representing. And so if you don't know what that special population is, then you can leave it blank, I guess, and we'll tell you what we assigned you to later. So, and I see Dr. Singer is on, so yay. So Dr. Singer, would you like to say any words as the head of the ISP portion here of the grant?
Thank you, welcome. I'm sorry I'm late. I'm calling in from vacation. I had another meeting that went over. So, I think that many of us know what the special populations are, but I think with COVID especially, it's become incredibly clear how important establishing trust and having different stakeholders help us with research, how important that is to communities. And if ultimately the job of the CTSC in part is to help improve the community's health that we live in, that we need to just harmonize the way we do things. Great. So thank you all for being on.
Yes, thank you. So once again, then to some of our objectives that hopefully we'll get out of this meeting here today is sharing best practices, like we said. So hopefully we'll be presenting some case studies that will help encourage a good, robust discussion, and we'll get out of the way and we'll have everybody, weigh in on how they see it and how they either see it in their clinics or in their practice, and what this looks like, and then where we can go from there. Help identify recruitment and retention with these particular populations. And then hopefully to help establish some citywide collaborations for future studies in special populations. I think that's the beauty of our grant. The beauty, and sometimes it's a little bit hard that our grant does cover 3 different or 4 different institutions, but I think there's some value in that then too, that we'll be able to cross collaborate and know who our counterparts are at the other side. So I think for you guys here as the participants, I think it's a really rich collaboration that hopefully we can build on it and just grow in the future, I'm hoping. So those are our objectives here for today. So then as we go into our case studies, what we'll ask everybody to kind of try to control the chaos, for lack of a better word, if everybody could use their raise hand function, and I'll try to monitor it and look and see that you guys are on 2 different screens for me, so I'll do my best to catch everybody and catch everybody's hand. If I'm not seeing you, please yell at me through the chat. That's great. Or if you have something that you want to say, if you want to say it through the chat, And if we're running out of time or something like that, please put that in there, because we're recording all of this, and we're also going to be documenting and saving the chat then too. So anything in there that's valuable information, please feel free to share it in both different ways there too. So, and nobody is actually muted on our end, because we want everybody to feel free to be able to speak and say what they need to say and all that too. So I will be a timekeeper as well. So if we're getting into a really robust discussion, I can give everybody a 5-minute warning too, that we're, need to move on to the next topic here. So with that, and does anybody have any questions or anything? We're not going to take any breaks as we go through here. So if you do need to take a break or take a call or whatever, we know you guys are all busy clinicians, please obviously step away, or if you want to turn your video off so I'm not trying to call on you or something, that'll work then too. So any questions or anything before we get started? Okay, we are right on time. So Jaleese, take it away.
All right. Hi, everyone. Thank you for joining us this afternoon, evening. My name is Jaleese Thomas. I work in the UH Clinical Research Center. I'm a research community outreach coordinator, and my primary goal is to expand clinical research infrastructure and opportunities at community hospital and ambulatory sites. And COVID-19 has definitely skyrocketed the urgency for doing so. So I'll just talk a little bit about what we did in the Office of Research Compliance, Education, and Outreach, which is one of the cores in the Clinical Research Center. And that was kind of meeting the need of ensuring that research visits did not come to a halt, as many other specialties had to stop their visits, by ensuring that we were tagging on to telehealth and all of the capabilities with that, especially with the government kind of relaxing some of the regulations to ensure that people still had access to healthcare. So I just kind of want to start by defining what access means. So it's permission, liberty, or ability to enter, approach, or pass to and from a place, or to approach or communicate with a person or thing. So obviously, COVID-19 threatened access to healthcare and research, but even before that, we knew that there was much room for improvement in terms of making sure that that access was inclusive to every and all demographics that we aim to treat and care for. So when we look at telehealth, the total number of visits for 2019, we had 10,754. The total for 2020, 402,860. So exponential growth in that realm. And in terms of the top 5 specialties that use telehealth, we had primary care adults, psychiatry, primary care peds, neurology, and cardiology. And to ensure that our PI, study staff, and research participants were able to continue their research visits, our team put together numerous educational pieces, from tip sheets and live courses that we would conduct through Zoom, or that we even uploaded to GPS, to ensure that people knew which modalities were approved and then how to use them. Because, we even talked amongst the team that's presenting today about how we kind of take for granted that people just automatically know how to use a smartphone. And then on top of that, the app, and then just, automatically have these capabilities on top of potentially nursing some kind of condition or disorder. We just have a lot of high expectations for people to get up to speed quickly. And what kind of tools, or how can we make that easier for them? So that was our focus with the tips and tools that we created for that. So to expand kind of upon the telehealth visits for research theme, we have a few questions for everyone on the call. So what are some challenges with the use of telehealth as it relates to your special population? So I know that for some of the special populations, like community and collaboration, I would love to hear some anecdotes if you have any, whether it's personal, if you had a telehealth visit. I know I actually had 2, or if you just kind of heard anything from the community, but any of the special populations, if you could just chime in with some of the challenges that you've seen over the past year.
Dr. McBoy, I see your actual hand up, so go ahead. And then Dr. Price, I think you're next.
Classic pediatric person, like I'm in school. With peds and with child psych, the challenge has been the confidentiality of adolescents. So it's been pretty smooth to do telehealth for psychiatry generically, because our physical exam is pretty translatable to interacting over a screen. We we've had progress, then I've learned to tell teenagers, what room are you in? Is the door closed? Who's inside or outside the door? But those kinds of things that I would have taken for granted are especially challenging with adolescents.
Okay, thank you.
And I was just going to say, there are obviously some areas who just don't have the broadband capacity, which is a huge issue everywhere. The digital divide itself in terms of being able to use the technology, and then for older people just not wanting to do it. They just don't want to do it. Even if you show them how to do it, it's just not something that is their way of engaging, period, but also around their health in particular, and the trust issues around talking about things about their health over, you know, a device. Like, what are we doing? So those are.
Dr. Price, have you been able to help pull some of those people into the conversation, or pull them into the 21st century, or?
With everything happening so rapidly with COVID, I don't know that nothing that I have heard of where folks have had enough time really to focus on that aspect of it, other than to document what the challenges are.
Dr. Farrell, I think you were trying to raise your hand but couldn't, so if you want to go ahead.
You think I would know how to use Zoom by now? I just blame on using Microsoft Teams as well.
Me too.
So one of the interesting things that we learned about patients' sort of perceptions of telehealth in the clinical sort of context, which may have application with the research context, we got a small one of the COVID-19 grants from the NIH. And so we interviewed pregnant women to get a sense of how did they want to use this technology in the context of their prenatal care. Now we know that telehealth has been applied in prenatal care before COVID, but the thing we found is that it doesn't work for all people all the time. There's a self-selection bias in those who chose to use telehealth prior to COVID. And in our interviews, we found that some women really didn't want to use it. They didn't feel that it was applicable for pregnancy. They felt that there was something very different about being a pregnant woman and talking about the issues related to pregnancy, at least in clinical care, which I imagine has some extension to research as well. And what we also heard was that patients said, you know, I'd like to use it. I understand why I should use it, but it needs to be tailored in a way that I can describe and discuss these very personal aspects of my reproductive and personal health care in that sort of format. So I think bottom line is telehealth is great, but it's not for all the patients or all the participants all the time. And if that's a modality that we will use all the time, just trying to do some research to understand what our patient populations and research populations would want based upon what makes them special in that nature. So pregnant women may be very different than lactating women who have a new baby at home versus other populations. So it's a great modality, but I think we need more data to understand how to use it amongst our special populations in slightly different ways.
Absolutely.
Does anybody else have their hand up that I can't see? Dr. Dell, yes.
Again, you would think I would know how to use this after all this time. Just two quick comments. I think one of the challenges, and this is both that we experience both in clinical and in research, is that, you know, for those of us in specialties that require procedures like blood pressure, it sounds simple, but, you know, most people can't do a blood pressure on a 2-year-old because they don't have the machine and they don't, you know, whatever. So there was, and this was true with several of the PED studies that came through where we had to sort of flip flop and figure out how to do things. But, you know, I think, as you said, it's great for some things. And actually, I think behavioral medicine is a great example, but, you know, for anything for procedural related things, even minor procedures, EKGs, things that just are required to, you know, do a safe drug trial, for instance, it can be really challenging / impossible to do those sort of things remotely.
So Dr. Dell, you did, because I know this, you had experience with having to put your research into some telehealth because we had to under the COVID areas. So can you talk a little bit about that experience of
Yeah, so we had, we had several drug studies going on in pediatrics, two of which were mine, but we had this actually across the board where we went to some form of remote where drug was sent to the families. And in that case, actually, some of them actually did have things like blood pressure machines. But I think that it was challenging. I think anyone who's done a lot of telehealth visits knows that, you know, getting the right platform and our platform changed several times during the whole process. So whoever brought up the issue of trying to re-educate people about what platform, you know, different hospitals use different platforms. So I think there's just so much variability. And so I think you could do it. But it depends on the type of study. Observational studies are probably more better ones to do it than, say, intervention studies. But you know, you can adapt. It's just you may not be able to adapt all of the study procedures to remote living.
Thank you.
Dr. Gupta, can you comment on your experience with the elderly? I know you have a lot of older patients. Have they been receptive to telehealth? I don't know.
Who was that question to, Dr. Raman?
So I have mainly be doing inpatients. And what I can do is I would ask our contact our outpatient providers as well to find out their experience. But in inpatients, you know, we've really not been doing those sort of virtual visits right now. It's mainly face-to-face. But what I would do is I would try to connect with our outpatients as well and get back to you as to what other challenges they have noticed. And again, based off of my experience and what I have heard is the technology in an elderly population, they're not well versed with how to use the technology. And that's why that has been a barrier in major barrier with this population. And they have to rely sometimes on their caregivers to set these things up for them. I think the geriatric population traditionally, you know, when they grew up, their era was a little different. So I think that is, I see as a challenge in our population for telehealth, not being that tech savvy, more so than younger population. And especially, you know, when you have this cognitively impaired, again, they're anyways reliant on their caregivers.
So with all that, has anybody had any experience with which populations or which demographics or which disease areas that telehealth was actually better? Do we have any of those situations? Who's got their hand up? Nobody knows the raise hand technology, I guess. That thing, you're not muted. So did you want to talk?
Yeah, I raised my hands.
Okay,
I don't know. You did not see my hand. I don't know why. I think to address what has been said already, again, you know, I take care of heart failure patients. So in fact, many of the really elderly 80, 90-year-old patients have amyloid. And so we have been kind of, they're all in Florida, and we actually have to do it telehealth for that reason. And one thing that we have learned a lot over the course of the last few months has been the involvement of their family members, the other caregivers, to help coordinate the communication. And I think they are actually very motivated to participate. But on the other hand, there has also been much more success, should I say, by just simple telephone. I think most people do understand how to use a telephone. And so I think there are advantages of having face-to-face. It gives them kind of a confidence in the communication. You can see visual cues, and you can see, kind of potentially things that people may be a little wary about certain things and stuff. So that even in the recruitment and consent part, I think there are benefits on having a video, call. To answer the other question about, access, we actually, it's not necessarily telehealth, but like, internet technologies. We find actually quite interesting in a recruitment for a precision health study that there is a high percentage of African Americans or minorities who respond favorably than perhaps if we just approach them on a face-to-face fashion. So I think there are benefits in telehealth when the actual, inquiry is agnostic. I don't know if that actually makes sense, that there are certainly some implicit bias in both sides from the, particularly from the receiving end too, for information receiving in terms of kind of the, approach in terms of asking, are you interested in participating in research, etc. So sometimes I think having some, neutral kind of approach, in this case, using kind of words or technology, sometimes there are benefits.
So you're saying the use of technology can maybe help mitigate some of that implicit bias?
Yeah, exactly.
Interesting. Okay,
yeah, the information actually surprised us in terms of like almost a third of the African American respondents actually respond, which is much higher than many of the studies out there when people are directly solicit. That's my point.
Anyone else have a hand up? We have about 4 more minutes in this module here. I know Cleveland Clinic did just put out at our State of the Clinic that they did help with broadband access in our own neighborhood, in their Fairfax neighborhood. Did you guys have any anything like that or anything similar happen at Metro or UH to help facilitate the use of telehealth in your areas, or that you had experience for yourself?
I think there is some stuff at Metro. I'm not, that was in the old Brooklyn neighborhood. Noreen, it's not really directly connected to us. Noreen, do you know the details of any of that?
I think there was a Fulton Road area neighborhood collaboration with one of the cable companies or broadband companies. And so I know there is several neighborhoods north of where Metro is, where they instituted Wi-Fi for certain buildings, many of whom had elderly persons in there. So I think they're trying to actively assist the near West Side area around Metro Health to have connectivity. But if I recall, tell me right, Nora, I think they had some type of agreement for at least 3 or 4 months of free use.
Yeah, and I think there was also an open Wi-Fi in Old Brooklyn. So I think it's sort of part of Metro's grander help with the neighborhood and redevelopment plan, which is probably why it really hasn't come down to us so much, because it's at the C-suite level that all this stuff is going on.
Got it. Well, I do see that some folks have joined us a little bit later, so welcome. So if you guys can please open up your chat. And if anybody else has anything on this topic while we're getting everybody else up to speed here that have joined us a little bit later, if you could in the chat put who you are, what your institution is, and what special population you are here to represent. So I will say this, I know I have a couple other folks that have told me that they're going to be joining a little bit late. So I'll probably say it in between each little module to give us a breather and get some water or whatever else we need to do here. So if somebody wants to put in the chat if they have anything else on this topic that they'd like to share, or even just one little thing that I don't know if our raise hand function is really working here. So I think we're okay making sure we don't talk on top of each other. I think we're doing a good job so far.
If you get people to look in the reactions button for the raised hand button, that'll help people locate it. Do you guys have the reactions button? We don't have a strict raise hand, but it's within the reactions button.
It's not
an Megan, there are a couple comments in the chat pertaining to the topic from Dr. Dell and Dr. McVoy.
Yes. Concerns about confidentiality and telehealth, yes. Dr. Dell's mother had a panic attack for not being able to get into the platform, yes. Yeah, and so, yeah, I think that the distance thing that, you know, is great, that people don't have to drive all the way up to our main campuses and deal with our parking situations that everybody hates. I think that is definitely an advantage as well, so. Okay, great, thank you. So we're gonna move on. It is 5 after now, so we're gonna move on to our next topic. Please, if you do still think of things with telehealth and access, please feel free, throw them in the chat and we will include these. We are gonna hopefully transcribe everything or at least get some good notes on this from our conversation here. We don't know quite sure how we're gonna deliver that yet. But then as you guys know, we are also recording this too. So we will get that out to all of the participants. So please, if you do still have something to share, please put it in the chat and then that will be recorded for all of eternity and then we'll be able to have that. So I'm gonna turn it over now to Kassandra and she can introduce herself and let her know what her topic area is. Take it away, Kassandra.
All right, hello everyone. I'm gonna try to stay in my seat. I hate the sitting down thing. I need to move and talk. But my name is Kassandra Spates-Harden, and I'm a participant recruitment specialist. I work in the CRU in the Learner Research Institute. One of the things for my job, or the most important thing, is to help researchers meet their recruitment goals. So it doesn't have to be one particular study, which I think is a really good thing with this grant, is that we can help anyone. Because with research, everyone is focused on their study, what they get funded on. A lot of times you don't get the collaboration across different studies. So that's one of the really great things that I can help people. So I want to discuss the importance of diversity in both healthcare and research and how they are intertwined. And when I talk about diversity, I'm not just talking about racial and ethnic, but gender, age, and life experiences. I know we have special populations that go across a lot of different things, but when I look at diversity in research, I'm really talking about the team, not just the participants or patients that you have. There was an article sent with the agenda. I don't know if anyone got a chance to read it, but before I get into the article, I just want to share a quick story about the need for my services and other participant recruitment specialists that can help any researcher. Soon after starting, I've been there almost 2 years now, I was approached by a study coordinator who had actually talked to Megan, which sort of Megan dragged her into my office and the lady was like, I need help. And Megan said, just say it, just say it. And I'm like, what? And she said, I can't connect to Black people. And I'm like, that doesn't offend me. Okay, it's a lot of different cultures I can't connect to. But she is a research coordinator, so she needs to connect to all people. She was like, I need help. I need help. She was like, I don't know. I had a Black man yell at me once and I just forgot what I was asking. And I know, Black people in Tuskegee, but I wasn't going to let her use Tuskegee as an excuse on why she couldn't connect. So of course I'm thinking, like one Black man yell at you and you don't connect. I would still be single if that was the case, because I've got yelled at by Black men in my life before. It's okay. But I did get her some Black people, and actually she was really interested in people over 70. So I got her some men and some women for her study. But the people that I knew, I asked them, well, what did you think about the study? They loved the study. Everybody loved the study. Everybody I asked did not, no one said no, and they actually were referring other people, but the feedback was, that girl is scared of Black people, or either she just super intimidated. And I'm like, she may not really have that many experiences with different cultures, but it comes out to the minority group that she's scared. So that was actually, I'm glad that she decided that she needed help and it wasn't working, because she could have just continued, kept going and saying, Black people just don't want to do research, which is not the truth. You have to ask. But getting to the article is about Dr. Susan Moore. She was a Black doctor who was COVID positive, and she went to a hospital in Indiana, and she felt like she was getting racist treatment. So she chronicled her situation, and she was in the hospital about, I think, like 10 days, if I remember. And she actually went, did Facebook Live, all of that, saying how she felt like they treated her like a drug addict. They didn't manage her pain. They didn't give her tests. They didn't give her medicine. She felt like if she was white, she would have gotten. So she ended up staying there for 10 days. Then she got discharged. Well, she went back to another hospital 2 days later and she died. The CEO of the original hospital where she felt like she was getting racist treatment, of course, he was saddened because she was, she's part of the community. She's a doctor. But he also said, well, the staff said she was intimidating and she was complex, which was like, how was she intimidating? But it makes me think of when my mom and my aunt who did that lady's study said, I think she was intimidated by us. It took her a long time to do anything. And I was thinking, is that just what, people say a lot of times about Black people as a reason to not give them what they need? And of course, there are other populations, but I'm just speaking about Black people right now. But when I heard about her, I went back to a case at one of our regional hospitals. It was a 65-year-old Black lady who agreed to do a COVID biobank. She was very nice on the phone, as nice as you can be being COVID positive. By the time I got from my office to the hospital, I gave the nurse, I stopped at the nurse's station. I gave the nurse the consent for her to look at. I said, well, take it to her, I'll call her. Well, I said, I'm gonna sit on this bench right here and I'll wait for you to come out the room. Well, he came back walking really fast and he said, she is just very difficult. I don't think she's gonna do it. And I'm thinking, what changed? She was very nice over the phone. So I called her, I said, what's wrong? She went off on me, said a lot of cuss words about the nurse. She said, he is not nice. He doesn't care about me. And this is a stuck-up hospital. I told him to get the doctor. I want to go home, which makes me think of Susan Moore. I don't know if that lady died when she left or anything like that. I didn't follow up with her. She said, I'm not doing it. I just need to get out of this hospital. Well, after talking, she finally said, Kassandra, I'll do it. I'll do it for you. She said, I'm going to do it because I like you. I'll do it for you. But we needed morning lab. So she couldn't do it because she needed to stay. And she said, I'm absolutely not staying. I'm going to go home. But I'm thinking, I don't want you to do it for me. I want you to do it for the research. But her health care and the mistreatment she got in her health care made her say, I'm not even doing research. And she would tell someone else that, and another person would feel that way. But when he called her difficult, again, being a Black lady, you often hear we're difficult, complex, loud, whatever. I'm thinking, what made that lady difficult? Because she was not difficult on the phone until whatever he did in the room. Well, he told me what she did. She told me what he did. She was done with research. She was done with Cleveland Clinic. She said, I'm leaving. But I'm thinking, actually, I missed a part. While I was waiting on him, I had on my Cleveland Clinic jacket. I was sitting on a bench when another nurse came up and said, are you with food services? Do you need to drop off a tray? I have no tray with me. I have a laptop. So I don't know why. I'm like, could I not look like a doctor? Why do I have to look like I'm with food services? So I said, no. Then she said, well, what do you need? I said, I'm waiting, with the biobank. She said, oh, I forgot about it. But it happened more than once, going into different hospitals where there are not people that look like me. And when I appear, it's like, well, who is she? Who is she? And actually another hospital, I've been followed with eyes down the hallway, like, where is she going? Where is she going? But when people don't trust the system, they're just not going to go back. And if I wasn't an employee, I probably wouldn't go back. And I've never actually said it like thinking about it as a patient, but the way that I get treated sometimes in certain departments, because everyone looks alike. And when they see someone that's considered an outsider or that doesn't fit, it's sort of a look and it's a treatment. It's like I've been stopped like 3 times in one department where you got to have a badge to get in. It's like, what are you doing here? And I know often we talk about diversity training and, that's a nice word to say, but I think there needs to be diversity in staffing, and that will lead to diversity in patient and participant population. So I know it's a lot of physicians on here who hire new students, who are involved with hiring, but I implore you to put the effort into that because that makes a difference. It's not just about, oh, you took a training on how, Hispanics do this or what, different Asian populations do. That's nice, but that's not going to solve the problem until you get people that can actually talk when they're not working about the, there are differences, which it's okay. We're different, but when you have employees that look different and can talk differently, you can make a change that way. And I don't know if Dr. Cedar ever joined the call, but one study I was working on for him, that was one of the big things. You are a nephrologist. A lot of your patients are Black. All of your staff is white. Why can't you hire a Black person who can help you recruit some of these people instead of have me, who don't work in that department, help you recruit people? So that's, there's some questions after this also. Megan, you can, or Jaleese, I forget who's doing the slides, but there are, you can, so it's some of the one, well, the last one is similar, like, what type of biases occur in other special populations? And I know we just got finished talking about like the elderly people, and, my father was old. I always say that. He was 56. He would be 106. God bless his soul if he was still alive. But my mom was young. A lot of times people look at older people like they just don't know or can't do something, and they just exclude them for research, but they should not be excluded. Everybody is different. Everybody's individual. If you don't ask, you won't know. And then what role does provider bias play in the scenario? And then what are some opportunities or suggestions on how we can improve bias in healthcare and research? So I'm finished. I'm off my soapbox.
Thank you, Kassandra. So does anybody have any comments on that they would like to speak on? I do have the raised hand function open, and I am looking at everybody. So you can just unmute, or you can wave to me, or however you want to do it.
Hi, it's Nora Singer. I will tell you, I'm sorry that you've had those experiences, Kassandra. I will tell you that during COVID, having an elderly parent in a hospital in a different city, that one of the things I've noticed much more out of Cleveland than in Cleveland actually, is that because everybody's remote, there's less talking to families on a regular basis that's going on. And also that some of this is generational. And so the older people as interns and residents were referred to as the patient's main doctor. And that's happening less now. And I'm wondering how that sort of contributes to the breakdown of the physician-patient relationship as well.
And Nora, this is Mona. I would just tag on to what you said. I would just say that an experience I had, there was a patient who was in a rehab facility here in our Hannah house, and his sister, who's the main caregiver, is a nurse in Akron. And in a nursing home, anyways, there are restrictions with the visitor, so she couldn't visit her brother. And the patient was somebody who was such a pleasant person that he wouldn't just complain, but he would talk through her sister. So she was his voice. So whenever you call her, it would be a long conversation. She had a lot of issues with what's going on, why this is not done, why that's not done. But mostly I felt it was all because of the communication barrier between the primary teams and the family, because each patient was a complicated patient. Each team was looking from their perspective, nephrology, nephrostomy tubes, cancer, wound, and apparently they were talking to the primary team, or they may have talked to the sister, but nobody was looking at the overall picture, and there was some miscommunication or lack of communication, for the better word, which was really contributing to this mistrust of what's happening to her loved one, and more so because she can't see him. So we are the only voice, and she just has to believe what we have to tell them. So what I would just say to that is that yes, these biases are more heightened during this COVID time, because patients, families, they can't see their loved ones. And then I just also heard something about difficult patient. We also need to keep in mind, if the patients are difficult, we need to explore why are they difficult. There's generally a reason, either they are some lack of communication, some some medical issues or some healthcare issues, we need to try to step in their shoes as well and try to see why are they behaving the way they're behaving. There could be a lot of issues. Could be just family members could feel guilt because they have not been involved in care, or truly there was some medical error. So before we judge label the patient as a difficult patient, if we try to explore from their perspective as to why are they behaving, I think that would help, and that would be an opportunity to improve that sort of a bias in our healthcare.
Thank you, Dr. Gupta. I have a comment, raised hand from Michael, and then Dr. Price, and then Dr. Farrell. So Michael, you're first.
So I just wanted to speak to about the types of bias in other special populations. So speaking from an LGBT perspective, I'm kind of blessed I'm in my little bubble here, but there is some folks hold on to this perception of choice, and that can pan out in the CRF forums about sexual preference. There's two genders. So really letting people define their own circumstances can go a long way. And I think kind of a very helpful way to circumvent that is going through a fine-tooth comb about, what kind of pronouns are included in your consents, because even from a personal standpoint, it takes a while to build trust, but you can blow it in 1 second. So I think just keeping that in mind.
I think those are really good points, Michael. Thank you. Consent forms, I read consent forms all the time, and I help study teams with consent forms all the time. And that's something, even though I know it, that's something that I have not considered. So thank you for bringing that to our attention. Dr. Price, you're next.
Hi, everybody. I work in community benefit, actually. So I'm not a doctor, but I appreciate the promotion.
Well, I just gave you a degree, so there you go.
But I work with a... Thank you. But I wanted to put this out there, and it may be something that's already happening, but I'm thinking about the use of community health workers, those either employed by the hospital system or those external smaller nonprofit organizations, and kind of going to the point that Kassandra was making of people who are already embedded in that community, who can talk the talk, who are relatable to the individuals, could help to add on that diversity. As definitely we should be hiring folks who work at the hospital in the clinical capacity as well, but the community health worker is also another way potentially to think about getting that diversity quicker. And people who, are very familiar with the neighborhoods and, may already have an easier way to build rapport.
Thank you. And then Dr. Farrell, I think you were next. And then Noreen, I think you were after that.
Yeah, thanks. I want to, again, speak to the issue of pregnant women, and mostly pregnant women. There's lactating women as well, but mostly pregnant women. I think when we consider bias, we often think about race and ethnicity, which is a very significant and important bias for us to consider in healthcare, particularly in pregnant women, where the majority of infant mortality is experienced among populations who may have minority status or lower SES. But also in the context of pregnant patients, there's also other women who are high risk for other reasons, who also may benefit from research. So I think about women who are using drugs, alcohol, opioids. And this is another population who really can face a lot of bias when people come to them and may have some biases about who they are, what their choices are. And I raise this because already pregnant women are a population which have some concerns about the choices they make during pregnancy. If they accept a trial, is that looked positively or negatively? Or if they decline trial participation, is that viewed positively or negatively by themselves, by their provider, by their family, by the researcher? So there's so much already sort of scrutiny of the choices that women make during pregnancy, which is acceptable risk or unacceptable risk. And then you layer on the bias either from race and ethnicity, but also some of these other high risk behaviors and health statuses. And we really have to be so mindful about how can we navigate that through, because these are the populations who could really benefit significantly from research, but we can't get them to recruit because of so many concerns about if their behaviors will be further scrutinized, if social workers will be sort of more involved in their care, and most importantly, if there may be a chance that their child will be taken away from them after birth. So these are all concerns that we have to address.
Oh, those are great points. Those are wonderful. Noreen, did you still have comments?
Yes, I did want to speak about a couple of comments that Kassandra made and improving bias in healthcare, especially research. As a former clinical research coordinator, I was a coordinator in my late 20s, and I found that the diversity at Metro Health really helped me to relate to a large number of people. But I also think it's not just the diversity, but it's the outlook of that person. Do we really look beyond any type of skin color, sexual orientation, and so forth? So, you know, the training that we do at our institutions to help us feel more comfortable in approaching people of all walks of life, all ages, all abilities, all sexual orientation, and so forth, I think makes a big difference. But again, Kassandra, I do feel badly that you have had those experiences. And I do think that the diversity that we work with at Metro Health and many other institutions has helped research, because we can approach people in a very compassionate way and in a way that they feel that we understand them in some ways, and we're offering them some research for either a benefit or not benefit, but we're offering it in a way that is somehow relatable to them, and we feel comfortable talking to them. So, thank you.
Thank you. We are at time, but this is a good conversation. I see a couple more hands up, so I'm going to borrow 5 minutes from the end of our session here. So Dr. Dell, you have your hand up.
Yeah, I just wanted to comment on bias on the other end of the age spectrum. So, you know, it's not uncommon that I have heard, and this is speaking specifically with provider, or I should say PI bias. There are a fair number of studies in a lot of different specialties where they will enroll, you know, patients down to age 12 or 15 or that sort of thing. And quite a number of times I've heard comments from the PIs who are adult providers, oh, we don't want to enroll kids because it's too much effort. We don't want to have to deal with the parents. You know, we don't want to have to deal with the extra forms. And, you know, I think that's it. Whenever we can identify, you know, it would be nice to identify studies that come through various institutions that have potential to enroll kids, and actually have a mechanism for saying, you know what, PI, it's not as hard as you think to enroll kids. And, you know, here's a pediatric person you can partner with who will help you sort of do the pediatric side of things, because it's such a lost opportunity for our kids not to be able to get some of those intervention studies in particular.
I agree. Dr. McVoy, you had a very nice comment on the chat. So I think this leads into our end here of what are some suggestions and how can we improve, and what are some things that are working? How do we address some of these either, you know, biases that we know we have, or maybe biases we don't even know we have? You have some thoughts on that if you would like to share that with everybody.
Sure, it just was a good reminder at the beginning of the presentation to think about who's calling for recruiting. And it was not something that occurred to me, which of my team members was calling for recruiting. And so it's the same one usually, and that is a good reminder that we can use the wide variety of RAs and, you know, all the diversity that we have available to make those recruiting phone calls too. So that's something I'm going to pay more attention to going forward.
So you mentioned in your chat that you are lucky enough to have diversity in your RA staff and researchers. Was that intentional?
I didn't hire them, but Martha Jadovic is the team I'm a part of. She's a geriatric researcher, knowing Martha, I'm guessing it was intentional, but it will certainly continue to be intentional in anybody that I would hire. I just have come on as a sort of newbie in her team, and I'm lucky to benefit from a diversity in race and gender and age. But knowing Martha probably was intentional.
It's Nora Singer. I have one other thought, which is our experience with our pediatric rheumatology network is that sometimes people will say no the first time, but that doesn't mean that they shouldn't be approached again, because people may be receptive to it more after they've gotten to know you or after they've heard more about it, especially from other parents. And so it's important to ask sometimes more than once.
No, I think that's great. Anybody else have any comments on this topic? If you do, you can go ahead and go into the group chat and put more comments. These will be recorded. And I know there's still some folks that have joined us a little bit late. So if you could, in the group chat, if you can put your name, your institution affiliation, and the special population that you're here to represent, that would be wonderful. Then we would have that on record then too. I think Dr. Njoku and Dr. Yepes Rios, I still don't have you in the chat, I think. And maybe even Dr. Ogboyu, I don't know if you may have. So if you did or didn't, if you want to put your name and all of that in the chat, that would be wonderful. Thank you. So with that, we're at time now. So we're going to move through, or let's speak now if somebody else has something they want to say. If not, we will move on. We'll give it a minute. Okay, so our next topic here is barriers to research. So I will let Nicole and Rebecca introduce themselves, and they can speak on their case study about community access.
Hi, my name is Nicole Bernardo, and I am a participant recruitment specialist at Metro Health.
Hi, I'm Rebecca Weintraub, and I'm a participant recruitment specialist at University Hospitals. Prior to being a part of the Clinical Research Center at UH, I was in the Department of Psychiatry as the Recruitment and Community Engagement Specialist. Basically, I not only support our research support core, but I also offer assistance to different recruitment research teams at university hospitals. So in addition to access to healthcare and bias in healthcare, there are many barriers when recruiting and enrolling special populations into research, including access to transportation, just one example. So one example on how university hospitals is able to address this barrier is regarding our COVID-19 biorepository study, which involves collecting samples from COVID patients within a 10 to 14 day window of a positive test. So even though we have a dedicated safe space to see the patients on main campus, we realized it would be less taxing and we can get a more diverse patient population if our research specialists went out to the patients' homes. So that is exactly what they've been doing all through Cleveland and the surrounding suburbs. So as a result, we have been able to enroll more patients, collect more samples from a diverse group of individuals out in many different communities. So this has enabled us to have a variety of specimens in our biobank for research. And we found this to be very successful. So this is just one example of a barrier and how we're trying to overcome it. So it leads us to some questions.
So the questions that we would like you to share your experiences and perspectives on are, what are some real and perceived barriers that you have come across in your practice and also with special populations that you've worked with? What do you think are some opportunities and suggestions on how we can remove these barriers? And also share your stories on any successes of removing or overcoming the barriers.
So for those of you who have joined us, if you can find the raise hand function, you can use that. So if you actually click on the participant button, once you already have the participant video up, you should be able to see, hopefully some people aren't, invite, mute me, and raise hand. And so I can monitor that and use that, or you can physically wave at me, or you can just speak. It's also okay. So I have Dr. McVoy, you're up.
So one best practice is calling Becky anytime you want to talk about recruitment. But one of the things that UH recently joined is access to a big database. The challenge for pediatrics, though, is the database then sometimes gives us the parent's name, sometimes gives us the kid's name. And so who we're allowed to contact and who responds to the contact is unpredictable from this big clinical research database. And so we've had little luck using that database as a recruiting tool. That was on my agenda to talk with you when we meet next, Becky. And I think partly because it's the kids' info we get, but it's the parent that is who we want to contact.
So is that something inherent within the database then?
I don't know. I think it's a pretty common thing within anything that's peds and medical record. The parent is who's in there often. Sometimes the kid, you know, so I think that's just something that didn't occur to me. And I think it may be pediatric specific, but I don't know if it's inherent in the database.
So Molly, they really shouldn't be collecting kid contact info. It really should be the parents' contact info.
Right, it's been hit or miss what we've gotten.
I'm really surprised that they have kid info. That's a little concerning, quite honestly.
Trinetics.
What?
Yeah, Trinetics.
Trinetics. I think we probably just need to give them a heads up about this problem if
right.
they're ready.
Molly, I can put you in touch with the person who runs the Trinetics,
yeah.
and maybe
we've told them. It just was one of those. Like,
yeah, that's definitely a challenge.
What about physical barriers to research? You know, I think a lot of us, if not, I know some of you guys are out in our actual locations. I know with us at Cleveland Clinic here, but what about just the physical location? I think so much of our research comes out of main campus. You know, I'd like to hear from some of the folks, even our own folks at the Cleveland Clinic out in our regional hospitals or our family health centers. Do you see research out there, you know, because we're just kind of stuck in our main campus bubbles, or, you know, our UH folks, if they are out, I know, Danielle, you're out in the community. Any barriers or positives or success stories that you have for research sort of outside of our main campus areas? Or lack thereof?
I don't know who you're asking, but I know I worked at UH for a study where we went to Chardon and we went to Ashtabula, and we had 100% yes. Only people that said no is because they didn't understand us. It was a language barrier, but they were so happy to get people from main campus to come out to those areas. And it was kind of funny because I'm thinking, I didn't want to drive to Chardon, that's far. And I definitely didn't want to go to Ashtabula in January, but the people were so nice and so happy. I mean, it was worth the snowstorms we went through, but they just didn't have anybody ever come out there. So I know, you know, maybe if it's a chance when you have studies, if you could do it at different locations, because then I know we went to Stephanie Tubbs Jones with Cleveland Clinic, and everybody again said yes. I could take claim it's me, but I think they just were happy to have someone that wasn't at the main campus that came out, asked them questions about the diabetes, and it was they were oh God, why can't I think it? When you go and you get your blood taken, oh my God, what is it called when not diabetes? Oh my God, when you have renal failure.
Dialysis. Phlebotomy.
I'm like, what is it called? But yes, we would go to the dialysis center, and everybody. It actually got to a point I'd have to go back different days because people would say, "Well, you asked them questions, you didn't ask me." And it was just, we were surprised, like it was really successful. They actually hired a second person because I couldn't give my whole life to dialysis every Saturday, but it was really successful. So if you have an opportunity to partner with someone outside of main campus, it's a good idea.
So I have Dr. Ronas, Dr. Tang, and Dr. Farrell. So Dr. Ronas, you're up.
Yeah, as I say, that actually builds nicely on Kassandra's comment. I think our experience has been the barrier once we can get in contact with the family, whether it's face-to-face in an exam room or over the phone, is not the issue. It's the partnering with the practices from which you're recruiting and finding a way that's going to integrate within their workflow in a way that's not going to disrupt the clinical operations. We do an annual cross-sectional survey with the two practices that we work most closely with, and we spent a long time in relationship building and figuring out how to really partner. And you need clinician buy-in, but you also really truly need front desk and PCA and nurse and kind of at every level and everyone working in that space to be on board with what is this research, how is it going to potentially benefit the patients this practice serves, and then what are the logistics that are going to really kind of smooth that process so it's seamless and not perceived to be disruptive or exploitative.
That's a great point. Dr. Tang?
Well, this is a very unique challenge, but when I was doing my work with the Amish, we actually do the remote. Obviously, we go there and, you know, and the interesting thing is the Amish population has their own IRB process. So our IRB would have very little understanding of what they entail versus, you know, their elders talk to them and, you know, this whole group meeting type of scenario. So that the readiness of research teams in terms of conducting the research is a big part. The second issue that we went through is that our equipment that we had to bring to the location were not insured outside the main campus. So you can go all you want to a place and have all the intention to do that. But the readiness of your research conduct, the procedures that you have to go through, need to actually go, things that you assume that you can do, even as simple as how to collect bloods and all that, you know, there are rules and regulations involved. And I think having standard operating procedures and helping our researchers in getting prepared is a kind of an asset for these outreach efforts.
And things you don't know until you find out you don't know them, right?
Yeah, so how will I know that my echo machine is not insured at Millerfield, you know?
Yeah.
Or even things as simple as if you can send somebody at a site and you upload it to the chart, which is the original source. That may vary from institution to institution.
I think your dog agrees, Dr. Singer. Dr. Farrell, you were next, and then Dr. Yepis Rios, you'll be next.
Yeah, 2 points. You know, I agree so strongly with everyone who's contributed so far, especially, you know, Dr. Ronas, what you just said about relationship building. The majority of my practice has been out in the region, and now I'm at the main campus, but my research has been out in the region the entire time. And there's such a different cultural difference and focus on sort of clinical volumes that we might find out in the region, the community health centers, as opposed to the main campus. And so trying to introduce and change culture about accepting and supporting research is truly important, because that's a huge barrier. And again, it's at every level, because if the front desk staff doesn't expect to see research staff around or can't help with sort of directing workflow, that's a real problem. But I think we have to come to patients where they are. You know, physically coming down to the main campus can be daunting for many patients, but also just sort of psychologically, if we can come to them, be out in the region, be available, and if they are willing to participate, do everything that we can out in the region, I think that'll help bring the research to them, as opposed to having them have to overcome that barrier to come to us to participate.
And I think that's where good, I'll do a shameless plug, where good research coordination comes in place then too, that you need to have those folks that are either there already, that are stationed out at your, I mean, because every single one of our institutions has a numerous amount of different community outside of our main campus. So, you know, really intentionally putting those people out in the communities and in the regional areas is key, I think, too. So
I agree. And to sort of know what those different areas are. So the first part of my career was spent at Hillcrest Hospital. And then the second part was at Willoughby Hills Family Health Center. And now I'm at the main campus. And those are very different places, even out in the region. So Willoughby is very different with their workflows, cultures, receptivity to research, familiarity with research than Hillcrest. So having some cultural, sort of a local liaison who can sort of understand sort of what the culture is and how workflows are, since we need to meet them, we don't need them to retrofit what we're gonna package up and give to them. And we really need to work with the local leadership and culture to understand what they need.
yes, good points. Thank you. And Dr. Yepes Rios?
Yes, thank you. I'm sure I'm unmuted. So we're very much echoing what Dr. Farrell just said. So I'm at internal medicine at our Cleveland Clinic, Ohio City Hispanic Clinic. And even though our title will tell you that we're serving the Hispanic community, I think we are not very rarely, if ever, tapped to reach out to that community. So kind of looking at it from two lenses. One is kind of working there. I do like small research projects, mostly connected with medical students at the Cleveland Clinic Learner College and the university, Case Western University program. So very much like Dr. Farrell said, when the students come, I'm kind of making sure that they meet everybody in the staff, the front staff, everybody knows who they are and why they're hanging out there and what they're doing. So having them introduce their project is key. And then working with the staff in terms of the flow of the clinic, because it is a clinic that's used to patient care. And just making sure that if this is going to work, it's got to work with the clinic and with the patients, and just to not interrupt that flow, and for patients to kind of understand the difference as well. So I think that is kind of key to the success. And then from the kind of the main campus part of it, I guess one would think if we want to reach out to more unrepresented groups, unrepresented minorities, to understand where those different clinical sites may be that are serving them that we're not necessarily readily thinking about. So for example, if I was sitting on main campus trying to do research on diabetes and include the Hispanic community, where is that community? And then kind of do the mapping. Oh, there's actually Ohio City Hispanic Clinic. So maybe being a little more deliberate about looking for those locations rather than, I think what we all do is what's convenient, what's close by, and just kind of more of that outreach.
Thank you. You know, I did have Dr. Eng, I see your hands up, but I did have a study team at one point ask me, you know, how do you reach these different populations? And I said, well, first you have to ask them. I mean, I think that's the very first barrier you have to get through, is being okay to ask them and know, you know, recognizing your own, I think this goes back to our bias, recognizing your own bias of, you know, I think Megan Miller, you're very good for saying this. I'm going to quote you, that all of our research participants can't be middle-aged white women. You know, that you have to break outside of that, especially with some of our cancer trials. You know, a lot of times that's what they are. They are middle-aged white women. So open up your own lens to see, are you even giving these opportunities for anybody? Or where are your providers giving, you know, serving those patients? Those aren't the only patients. Are you even giving those opportunities to those patients? So I think that's a great point, Dr. Jeffers. And then Dr. Eng, you have your hand up. So welcome. Thanks for joining us.
Thanks for having me. Can everyone hear me?
Yes.
Oh, excellent. Like Dr. Yepes Rios, I'm also an internist, also a pediatrician by training. I'm over here at the Lakewood Family Health Center, providing care in the Center for LGBTQ+ Health, and also work in the transgender surgery and medicine program. And my previous experience with working with, you know, air quotes, hard to reach populations, really when we're talking about sexual and gender minority populations, lesbian, gay, bisexual, transgender. And now we're really talking about queer questioning, intersex, endosex, and all other parts of the alphabet in terms of identities. I think that one of the things that rings true is visibility and inclusion, and not about me without me. So when we're thinking about our diverse research staff, thinking about all elements of diversity, as I think others have spoken briefly to before, but when that is absent in terms of demonstrated, visible ways to show that we've included folks in that research process in terms of delivering research, whether they're surveys or other types of tools that are being done in terms of populations to study. It can certainly continue to make people feel somewhat objectified or stigmatized already. My experience working with both medical students and public health students at the School of Medicine has been very positive in terms of being able to include the research protocols in a way that informs, I think, all members of the work environment, from our front patient-facing staff to all those taking care of the patients, all the caregivers. And also it informs the participants themselves, but also we have significant buy-in from community, oftentimes aligning with various organizations to kind of otherwise vet or support the kind of research that we're doing. For example, the LGBT Center of Greater Cleveland and other community organizations, can be very helpful in being on the community advisory board of some of the research that we're doing. So that we're being thoughtful and inclusive in many different ways. So I think that there are very important perceived barriers that we could certainly address by being very thoughtful and intentional in how we include people. Thank you for letting me contribute today.
Yeah, thank you. So you actually bring up a good point about community advisory boards. Does anybody have experience with other community advisory boards? And then how do we interface that then with research? I know Dr. Dell, I don't know if you're still on because I know your video is off, but I know you and I had talked about that. There is a pediatric community advisory board, but has there ever been a research presence there? And can we kind of seize on some of those opportunities? Does anybody else have any community advisory boards that either that you've used or not used, or how we can leverage that for research? And you can just speak now, I think, too. We're kind of at the end of it here, so all hands on deck.
So I think one thing that I discovered, I interviewed somebody recently who had involvement with the Sickle Cell Foundation or Sickle Cell Association, and they actually had put together some sort of community education resource person, people that they trained, volunteers that went out into the community to help. And it occurred to me that using that sort of, using that person as a way to let potential patients know about studies, they wouldn't necessarily have to do recruitment, but even just hearing it from somebody who is less of a stranger might actually be a very good way. So, tapping into either disease-specific groups or groups that support certain minority groups really might be a nice way to actually have a way to introduce research in a non-threatening way.
No, I think that's a great point.
We've used the community board for the Center for Health Disparities at Metro about how to approach research projects or how to get the community involved. But the other thing is I was at a patient recruitment day at NCATS almost 2 years ago now, and they use an idea studio where instead of doing focus groups with the community, they bring people from the community in as the protocol is being developed. People who will be the people who are being asked to participate in it. And so it's not, the research isn't in understanding what people say, it's helping the community to help you design a protocol. And so for that, you don't really need IRB permission, because it's not like focus groups where you're actually analyzing the material that they say. But I found that to be an interesting model of how to build a study if you're building it from scratch.
Yeah, that's wonderful. Anybody else have any other comments? Dr. Ronis, you said you do have some experience with the Community Advisory Board in Midtown. Can you share a little bit about that? I know we're getting close to time here. I think you're muted, Dr. Ronis. Maybe that's why you put it in the chat, right? All right, so we'll have that as an archive here for that. You know, I do know too, another important piece just to kind of complete the circle, and with some of you prolific researchers out there, you know, I do think the importance of then disseminating results in a way that a layperson can do, you know, not just, yes, we all know clinicaltrials.gov is supposed to be our, you know, open source or whatever, but I do think really having those results and being able to get it back to those communities, whether it's your actual study participants or just then the communities that you're asking for, you know, that really helps complete that circle of why are we doing the research. And, you know, even for me as a personnel in research, it's very nice to know that your efforts were not in vain and that they did have some kind of results that came to fruition for that. So anybody else have any comments on this? Because we are getting to time here and this is fantastic.
Megan, I think that's such an important comment to raise, this return of results. This is how we can build communities and trust across communities. There's nothing like a community who will take the step forward and engage in studies, and then the data is not returned back to them. They don't benefit from it. It's used for other communities, and this is seen over and over again. So Absolutely. This is so key as we build into our protocols, not just how to sort of engage in sort of community boards to develop the protocol, which is so important, but also we think about how can we return the results in a way that's meaningful for the community and they can feel they see that too.
Absolutely, yes. Okay, so where do we go from here now? So, you know, hopefully in talking to our executive leadership here with our grant team, we'll figure out the best way to disseminate all of this information that we've come together. I think some really great points have come up with excellent discussion here. I know a lot of us on our team here, our team leads, we're all taking notes, so we'll probably compare notes as well to, you know, what stood out with us. So we will figure out how we will best disseminate all of this information and sort of what key best practices came out of this discussion. I do hope that, you know, once we do, I think I said this earlier before a lot of people came on, but once we have a nice, robust point persons chart that shows each of the different areas and which special population we're looking at, and then how that looks across of our 3 different institutes. I would really like to share that with this whole team and then build on it. You know, I think Dr. Tang and I and Dr. Ruth, Farrell, we've all talked about, you know, how can we really expand this and make this a bigger thing, more meaningful, really get out into the community more and really find out who we don't know, who some of these point people are that we don't know because we've never asked them. So Dr. Della saying, nice to develop a list of community groups and point people for researchers who may want to approach specific populations. Thank you, everybody.